different private sector engagements are also different. So health is something that is like always seen as governments. It's the responsibility of the government to deliver these services.
A fourth of all those cases that happen globally on tuberculosis happen in India. If you're coughing, where will you go? Is your first port of call the TB program? No, it's your neighborhood doctor most likely.
Enterprise agencies could manage it. They cover up with the behavioral issue the government approached the private. They also said, okay, so it is, because that's not your construct, that's not your skill. Okay, so entrust people who have that skill and let them go and at scale.
I think communication is really a key in engaging private sector. I think it doesn't come automatically among all officials in the government, but that is a skill that needs to be developed.
So I don't know how many of you are familiar with, we have the infamy of being a largest contributor of TB problem globally. Okay, India has that infamy. A fourth of all those cases that happen globally on tuberculosis happen in India. Yet at the same time, TB is a very rare disease at the population level. So we have these dual problems. Aggregate, it's a big problem, but relatively, it's a very it's a relatively rare problem to find. A few years ago, a second challenge was realized, which is of these 1/4 of the global cases, half of the cases are diagnosed/misdiagnosed and treated in the private sector in India. And then that sets the stage to say, if we want to defeat TB, although we have a very strong, robust TB control program, which now is called the National TB Elimination Program, that program must find itself out of their offices and rooms and go into the world out there and do something with the problem. We have a very strong program, but are patients coming to our program or are patients going wherever they go? Again, I can ask this question to the audience. If you're coughing, where will you go? Is your first port of call the TB program? No, it's your neighborhood doctor most likely. So then the program says, I will go where the patients go, and then I will have to change the way. That's the origin of private sector engagement. Okay, it's to help the patients eventually. What the program was asking private sector providers to do was not palatable to the private sector. For example, they said, if you find a coughing patient in your private practice, please send them to the TB program. No doctor is going to do this. This brings you to the point where one needs to understand the world of the other partner, if there has to be a true partnership. Okay, so thankfully these things were recognized, and they said we got to do a 2.0 of private sector engagement. And the beginning of that was in the National Strategic Plan for the TB program in 2012. Again, some people sitting in the room contributed in the background towards making this happen. I'm just going to give you a glimpse of the kind of work that we did. So a very large-scale community-based survey was done, first to find TB patients, whether in public or private sector, and then trace back their patient care pathways. Which doctor did they see when they got diagnosed? Before that, which doctor did they see? Before that, which doctor did they see? How many doctors did they see overall? How long did it take for them to get diagnosed? Because that kind of information was useful to then say which provider should we target. And if we target certain types of providers and not others, by how much can I reduce that diagnostic delay? So that was one type of research that we did. The other type of research we did was, how do I start changing the practices of private providers? Pharma companies have done this for long. They send sales reps to pharma companies in a bid to change their prescribing behavior. Can we use similar ideas but for a public health goal? If I have a new diagnostic test for which the doctor is not going to necessarily get any commission, can I convince those doctors to start prescribing this new test, or even sometimes directing the patient to a public health lab just to get this test done, and then the patient can come back with the result to them? And so we looked at the effectiveness of such models to change provider behavior. The other interesting thing is a diagnostic test only gives a result. That result is an input to the decision making of the doctor, right? So we don't want to incentivize the doctor only to order a test. We also want to ensure that the results of the tests are integrated in the decision making, the diagnostic decision making of the doctors, and to what extent is that happening. And pilots were successful thanks to efforts of many people who are sitting in the room, not me. I just documented this stuff. And then luckily things didn't stop here. The next step, I'm going to skip through this. The next phase was scaling up this pilot, which was itself at reasonable scale, but 2 cities is not India, right? So then a lot of effort was taken in the background to say who will fund the next level of scale up. And this happened across dozens of cities, in at least a dozen of states, where a similar idea of an interface agency to engage with private sectors at scale was taken up. Eventually, after that, the third round of scale up was a big loan from the World Bank directly to the government. So now look at this, okay? Initially, some grant funding to experiment, then a more scaled up financing, multilateral financing to ensure that these ideas are indeed scalable. And after that, eventually the government owning up and saying, okay, we must do this. This can be done. This has the desired consequences. So we will take a loan from World Bank to then scale it up further. We started now studying, can similar ideas be applied in other disease domains, and especially non-communicable diseases, about hypertension, about diabetes, about nutrition. So if I want to increase fruit and vegetable consumption in rural areas or peri-urban areas, can I similarly find a way of engaging with informal vendors who sell fruits and vegetables on the street and figure out a business model? Because the whole idea is of creating a win-win. Dr. Shibu, by the way, he's one of the key orchestrators in the big, thing that I described. He was leading one of those private provider interface agencies in Mumbai. And so that's why I'm going to start the question with him. Shibu, you've before this big initiative, you actually worked in the public sector, correct, right? You were a district TB officer, correct? And so you would have seen the other side of public-private engagement, and then you moved over to the dark side. I'll just call it that. We are in a business school, so I'm allowed to say that. My question to you is, when these pilots were being conceived and designed, and now you look back on them, what were the key differences in the way private sector engagement was approached as compared to the earlier approaches? Would you start with that?
Yeah, so I recall my days as a district TB officer. That time also there was a private sector engagement strategy. So it started in 2003 by Government of India, supported by bank, and then supported by WHO and CDC and other partners, recognizing there is a threat outside. But as you mentioned, it was all so you come, you refer. And also started actually shaping up to you refer, we also kind of offer services. So refer and offer, right? So again, I can give you drugs and logistics. Then it evolved to, okay, you start your lab, TB lab. I will offer you money for it. I will assure you quality assurance. So we moved a little bit beyond. But none of these strategies was working because of the bandwidth issues and the behavior from the government side. So government is constructed, okay, those patients who are coming to me is a primary service client for me, and I have to satisfy them. And I have constrained with that budget, right? Okay, so in the moment I overstretch to extend it to the private sector, that's on me. Like, okay, why you want to do that? Because that's a behavioral issue. So, and again, the behavioral is all regulatory. Well, you are doing a wrong practice, right? Okay, so I'm offering the right service, so this is wrong. But in clinical practice, you won't see the same, the two different doctors behaving the same way in approaching the same patient, maybe same disease also. There'll be subtle differences. So that was something government standardization jacket versus the private kind of freedom to treat my patient in my way. That is a disconnect. There was a disconnect between the drugs also, because the popular drug regimen in the private sector was a daily regimen versus the government was pushing twice-weekly regimen, which was perceived as suboptimal. And then government changed over a period of time. So the key change was realization there is an issue, which you said. And 2009, there is a joint monitoring report which came from external experts used to evaluate TB program and said, hey, that you have been doing something, but it's not working. There is no evidence. But your problem, you are stagnant in your case notification, your reach. The problem is not with the public. The problem is outside. Okay, so what is the change? And they articulated clearly, you don't have the bandwidth. you have to have an interface agency. So it came from a bank study. Actually, bank initiated that. I was fortunate enough to be a part of that, orchestrating that when I was in ministry. So they came up with a document saying interface agencies could manage it. They cover up with the behavioral issue the government approached the private. They also said, okay, so it is, because that's not your construct, that's not your skill. Okay, so entrust people who have that skill and let them go and at scale. So, and then we got the Mumbai opportunity. So the key change was kind of understanding there are different animals in this ecosystem and approaching them with their needs.
Thank you, Shibu. So I'll come to you next. You also have a history and experience in public sector. You were medical director for the Suvarna Arogya Suraksha Trust in Karnataka. And in that capacity, and later, of course, at NHA, Director of Health Policy and Hospital Engagement. So you have also been on the other side trying to engage with private sector?
Different private sector engagements are also different. So health is something that is like always seen as governments. It's the responsibility of the government to deliver these services. But then we realize that tertiary care is something that, however, in the next few years, still we will not be able to, scale up our systems to that. So in that sense, and when governments want to promise some things to the public, saying that we do give you free healthcare services, including tertiary care, then they get to realize that how do you engage with them? And I think in that sense, one of the things that really helped us to actually engage better was having a good contracts with the private sector. So they knew what they could do, what they could not do, and they knew how much they would get to be paid for, and how they are a part of that negotiations for the kind of payment structures that that they can expect from the government. Because we did have a disciplinary committee, because we also knew that not all private will engage in bad practices, but still we need to have kind of an oversight committee to look at if there are deviations, if there are grievances from our beneficiaries, how do we engage them and how do we address them? Because finally we're accountable to the public. I'll just shift to a national level a little bit, because at the national level, when we come out with policies, do we really engage the private sector when we are finalizing these policies is also very important. Because during my stint, we very clear that we need to have the stakeholders' participation. I think communication is really a key in engaging private sector. I think it doesn't come automatically among all officials in the government, but that is a skill that needs to be developed.